Hey, what's up? Just left this up on the board. So, very simple, just a window into thought process in how we look at how we spend minutes. That's I don't when I do these whiteboards, I don't really expect there to be anything like dramatically earth-shattering, but I do think that very often there's at least when I would get to someone, there's some really good things that the individual has done or has been advised of or had been treated. But if they're not happy or there's no result at all, it's not because any of that stuff was wrong or any of the stuff that I'm also suggesting is so out there or outside the box. It's more about putting everything together. And that's I think that's the thought process that I'm really trying to get across. Okay, one of the best amateur golfers in the state of Florida, considering dropping out of a very significant tournament coming up because of significant pain that appears to be associated with wrist extension, right-handed golfer, so it's in his right hand. All right, so we start to think of some things. He gave me this little bit of a timeline, okay? So dating back to November and January, 2 cortisone injections. In his mind, everything was cortisone. Whether that was true or not, again, I'm of the belief cortisone works 100% of the time. Does that mean it's a substantial amount for the correct amount of anti-inflammatory for the inflammation? Doesn't always match up. Is it always the correct location? Is cortisone always the correct steroid to use? There are others that maybe are a little longer lasting, particularly when you talk about using those types of things with a golfer with a hand problem. Gets better every time, and if he takes significant time off, then he feels great. And if he gets into a lousy position or a shot and it was really jammed back into extension, then we have an issue and it comes back. So cortisone is not really helping. It's clearing out the water from the basement, but it's not doing anything to affect the hole in the roof, if you will. Okay, so you see here, we described this ebb and flow of sad face, happy face, sad face, happy face. MRI in February, and here's what we got, and here's what we were able to provoke. And then we'll get to the full body stuff, which is obviously significant. So number 1, tendinosis on the extensor carpi radialis. Okay, 0 symptom provocation with anything. Number 2, slight fraying of the TFCC. So that's where we're kind of harp on these things, because I don't know of any technique that can directly improve or restore the cartilage, except slight fraying doesn't really sound like a big deal. It shouldn't be something that's always a problem. But if it is, then obviously you start to see we did talk about some things. Next, what else was on there? Flexor carpi radialis. No, that's not his issue. We're not really able to provoke it, but we certainly put that in our bag. Now, I looked at the MRI then and the radiology report. Didn't see any films, only because it came in this chronology. So I tried to just stay lockstep with how this individual was telling his subjective story. So had a very significant 5-iron shot where it was totally fat. His wrist just exploded in his mind and has been in significant pain ever since. He has received other injections, some of which he's showing me, like I have no idea what they could be treating. He described that one physician, he said, show me where it hurts, and he just put the cortisone shot right there. I said, sorry, I don't really know what they were targeting there, but I think we should be able to feel comfortable that, at least at this point, it has not been a part of a good result. He has had acupuncture. He has had the wrist manipulated with a high-velocity technique. Nothing knocks this out. So we're in an interesting place, because the only thing that we could provoke that related to anything of substance on the MRI was significant forced infield into extension. And if that is the TFCC, except slight fraying just doesn't add up. It doesn't make perfect sense. It could be where we wind up. This individual could be very, very sensitive. The MRI could have been read a little bit suspect, or perhaps that MRI from February is no longer the same snapshot of what's going on in that wrist. All of these things are very, very possible, none of which we're going to have any ability to confirm or deny until we get another MRI, which is probably not likely. We're in the real world. The only other significant piece, aside from a musculoskeletal component, history of labral tear, and I think we're going to compartmentalize this labral tear as a right shoulder stabilization, SMCD, because the motion is brilliant. Remember, this is a great golfer, and even though it's not necessarily from a musculoskeletal pain perspective, he's not in the best shape. This individual's individual's overweight, challenged to be committed to training, etc. But he's great at golf, and we've seen that. And I think, as an aside, the real bucket commentary, really of all types of athletes, we've seen, and again, I've made it very, very clear before. In my opinion, the most talented athlete to ever live was a gentleman that I worked with in Philadelphia, and his name is Allen Iverson, and never did anything to generally prepare. A lot of specific preparation because the dude, like most basketball players, just love to play. And really, what does that tell us? That you can be great at your sport. I don't know that you can be durable without being very adept to general preparation. And I think that's very, very key for the game of golf. I think being in shape helps you practice with efficiency, which allows you to be consistent. And I think it allows you to be more robust towards these injuries, these overuse injuries, or some of these mini versions of trauma. That's my opinion. Because obviously it's very key. You can play the game of golf and be very weak and or very much out of shape. That doesn't mean you're not good at golf. It doesn't mean you can't generate great power. You're just not getting it from F. You're getting it from a lot of A, which you're getting from mobility. All right, that's off my soapbox. Let's get back to helping this individual. So we've got this labral tear in the shoulder. Okay, so maybe it makes sense that the stabilization strategies at the shoulder, the overall fitness, is not making him as robust enough to tolerate these forced extension. Okay, so worst case scenarios at TFCC, MRI is soft, so then that's really his problem. So we're going to say there's a lot of things, everything is on the table here. And I don't think we would ever jump directly into anything. But then I drew that line of conservative to aggressive. So we would rest. And here I said, you already know this. You take a rest and your wrist doesn't hurt. That should be on our list. I don't think that's any kind of a long-term solution. But if you rest and it feels better, then that's a good thing. Then we're going to move into our 6 buckets: training, rehab, sleep, nutrition, load management, and psychology. I don't have any expertise in some of them. I've got minimal expertise in others, etc. So that's going to be part of any combination of other procedures. I will get to what we did from a rehab piece. As you see, treating the pronator quadratus seemed to have a dramatic result. But as we move, let's say, if it is the TFCC, then I don't know that anything that we're going to do is going to regenerate the cartilage with those conservative approaches. We have to move down the line to things that are more aggressive, and what we're probably not going to be able to do in a fitness or a physical therapy environment. Doesn't mean you can't do other things to support the process, but we're not going to change that. So if this is really an anatomy issue, patho-anatomical, not a whole lot we're going to be able to do with physical therapy. But we're not going to give up, and we'll get back to how treatment fit into this. But then cortisone shots, these dudes had 5, a couple of which make absolutely no sense. I don't know that that's a continued approach. 5 in such a short period of time. Again, I'm not that concerned when cortisone is plugged into a joint space. But if it's going directly into structures, you're gonna. This is it's not working. At the very least, it's not working. Okay. Other types of things. PRP. If he is getting swelling, I don't know why PRP would be considered. However, PRP with stem cell, that it may have a role in regenerating some cartilage at the wrist. Prolotherapy, which is addition, because he asked specifically about that. Again, I have no downside to that as long as you're not sticking it in a nerve and leaving it in a nerve. My opinion on prolotherapy is that it can be very, very effective, but however, I think it's the needle that's doing the work and not necessarily the saline. And obviously, we move towards procedure. I typically use the word procedure instead of surgery just because it's a little bit of my own wordplay in terms of psychology. Okay, nutrition was a significant piece because I said before you do anything, you want to pick a couple things and really dial in. So training is somewhat a part of his environment. It's just not tumbling. He's not, it does. If the results aren't there, it's from the work you're not doing. So nutrition, and they say, well, how would we do that? I said, well, if I'm managing it, would just be very, very simple and very, very low pressure. In the 4 questions that we've talked about in other videos, are you eating enough calories? Do you have enough protein? Are the carbs supporting your training? And where does fat fit? So we have nothing on that. So I said, just start tracking your food and I can start to help you. And obviously I would refer him to other people once this got tumbling, because that's about as much as I can do in terms of helping people with nutrition. Maybe just get the bags loaded onto the plane, but I'm not the one that's going to be the pilot. You see in extra, in red, supplements. That's again something he brought up, and I don't have any. It's not something that I can do, so I typically shy away from discussing it just so I can't get into any kind of trouble. That being said, I think safe, effective use, things that are managed by very, very intelligent, credentialed people are going to probably have a good role in supporting all of the general preparation and work capacity that will allow, number one, the rest of the body to absorb force into the next fat shot, so the TFCC or whatever the anatomy is that's provoking this threat response maybe just isn't as sensitive, and all of those things can be of use. But after we finished, we talked a lot about training and in terms of what we can and should be doing to not provoke the wrist, but also stabilize the shoulder. Obviously, all other forms of training are going to indirectly support this. But I needled pronator quadratus, and that's a very interesting piece because no issues in this. I don't necessarily know how to specifically test pronator quadratus without pronator teres. So, but it wasn't like a rock. So we treated it. So you got a couple jumps. We know the jump sign, just like cavitation, should not be a sign of success or failure in the treatment. But we did get multiple jumps, and pain was gone. So at the very least, we can say that some percentage of this issue is not from the TFCC. Now, why would we treat the pronator quadratus? Because it's not that this was a pronation issue. It's not like he's pointing directly at this. But if that muscle tissue, and if we look at it as connective tissue, which of course it is, it's contractile connective tissue, but it's still connective tissue. And if it was creating tension as a result from trying to minimize extension, then I think it could become incredibly tense and then almost add to an impingement of the wrist. So if we were to say that the TFCC could impinge in wrist extension, then we should also be able to say what's kind of next to it. That's my thought process. Like, what else could be putting tension into the dorsal wrist so that when it extends, it causes this pain and pinch? Well, the pronator quadratus is the next thing there. So, and maybe I should have used some hands first, but I'm like, hey, let me try this. Bang, done. And then we're jamming his wrist into extension, and he didn't have pain. We also treated the very proximal portion of the thenar eminence. Well, why? Well, in my mind, if something was impinging from the top, then maybe there was something that could also have connections, if you will. And again, I'm thinking a lot of fascia, but I'm just trying to be very global in how we explain this because I don't know exactly what the structure was. I do know that I put it into the thenar eminence and I put it, almost along the line of the first metacarpal that goes obviously going into the thumb. So right now, what we're going to do is take the next couple days and do everything he would normally do, and let's see what shakes out. We might be, in one of these situations where everything goes as planned, and everything's good to go. If the pain comes back, then we probably should be re-engaging with his hand surgeon and start to explore some other options. I know that stem cells are available for this type of problem, but the MRI is not consistent. That a lot of things add up that maybe is not the TFCC. So and certainly this is not an active inflammatory process, because if you needle a soft tissue, a muscle, and all of a sudden the pain is gone, one needle doesn't take a shop vac and vacuum out all of the inflammation or fluid in a joint space. Cortisone can do that, but cortisone hasn't worked. So thought process here. I actually think this is going to be one of these, hey, like, let's just try something. That was my rationale. That's what made sense. And it's really about these links, these connections to where the threat appears to be emanating from, but it may not always be there, and it may not always make perfect sense. We should take the approach that everything is connected, and if there is excessive tension in one area, if you can temporarily relax that, then I said take 5-pound dumbbell and let's just work pronation from a supinated position to neutral, and let's see what shakes loose over the next couple of days. So hopefully that makes some sense, as well as making sense that if anybody anywhere ever happens to see a leprechaun, say yeah.